This is Joachim Runne, who is here from Region Norrbotten and their guideline editing team. Thank you.
Yes, thank you very much. Thank you for the opportunity to come here and present, you could say, our regional way of handling the kunskapsstyrning or knowledge-driven management in Norrbotten. I'm going to use the term knowledge management in this presentation. I'm a senior district physician at a healthcare facility in Norrbotten, also a chair of the local program area or lokalt programområde, primary care in Norrbotten, and a medical advisor for Region Norrbotten. Can I use this one for changing the slides? So, shortly about the Swedish system of knowledge management's overall vision. It is commonly formulated as this, with the overall goal of a smarter, more resource-efficient and equitable healthcare that reduces disparities and outcomes and enhances quality. Now, this is to a high degree a relative goal. I mean, no one wants a less resource-efficient and unequitable healthcare, and also has a high degree of abstraction. So it's quite hard to operationalize on the clinical level. In somewhat more operationable terms, this can be said as we use the best available knowledge in every encounter. New knowledge can be quickly implemented. Patients and professionals identify and prioritize needs together, and it is easy to work knowledge-based. So this is just an overall structural figure of the organization of the knowledge management system. Quite complex, has 3 levels that correspond in organization to each other, the national, regional and local level. And I'm going to speak about the local level in Region Norrbotten in this structure. So what does knowledge management really mean in primary care? Well, we have this vision, as I mentioned, and the operational goals. From a primary care perspective, to use the best available knowledge in every encounter is quite a vast task, as we are characterized by a wide range and volume of patient encounters. Consequently, there is a large amount of new and potentially useful knowledge to be implemented in this primary care, which calls for vertical and horizontal prioritization, and this is needed within the present resource framework that we work inside. And if it is to be easy to work knowledge-based, then a relevant knowledge support must also include horizontal prioritization and resource allocation for what we are to do. Some short words about Norrbotten County that I'm presenting from. We are in the northernmost part of Sweden, as most of you probably know. We border both Finland and Norway. We host quite a small part of the Swedish population, only 2.5% or 250,000. By contrast, we have a quarter of the land area, so quite scarcely populated. And we have a scarcity of physicians, both in absolute and relative numbers. In fact, we rank the lowest in physician density in all of the Swedish regions. We also, by tradition and necessity in this large county, have a strong primary care. So, when we started working with knowledge management from a primary care perspective, this was kind of our dogma, you could say, that primary care and no one else should define our area of competence, because no one else can do it, to be frank. Put in a more different and quite funny way, I would say, by a colleague of mine, one more initiative to strengthen primary care and we will perish. It is not without quite a deal of truth looking historically, because there have been numerous attempts and initiatives to strengthen primary care, but most have had no or even the opposite effect. So what do we do to succeed? I'm going to share 2 examples with you today. We have this local program area primary care, And we are experts on two things, primary care and Region Norrbotten. We host a wide competence. Practically all healthcare professionals are represented in this group. And we also have executive competence within the group. We also have a wide geographic representation, so we encompass all of the county. And we handle issues with region-wide primary care impact. For example, resource allocation, primary care versus other types of care, working structures and strategic development in the region. We work on behalf of the Knowledge Management Council, Kunskapsstyrningsråd, national referrals, our own initiative, and also local clinics in Norrbotten. As for practical purposes, we meet once a month, do quite a lot of work in between, but this varies quite a bit. And these are some examples of work we have done in 2025. We have developed principles of prioritization for primary care to be used unanimously, assessed 5 national care processes from a regional perspective with resource focus. We have had a local working group for care responsibility, and we have also had a local working group for cosmic primary care, our new digital patient records management system that some of you probably also are starting to get now. And we saw a need to have a special group addressing the primary care part of this system. Most of these are on our own initiative, not the national care processes, of course, but the other ones are on our own initiative. Again, a picture of this structure of knowledge management, and to illustrate that we're but a small part in this pyramid. The second thing that we have are the general practitioner consultants, or allmänläkarkonsulter, ALK organization. This was originally a local collaboration between primary care and hospital clinics. And it is kind of a local implementation of knowledge management system, you could say. It is based on 1 primary care representative per program area within the knowledge management, and we aim to have 1 for each primary care facility in Norrbotten. They are roughly the same number. This person represents primary care in knowledge management within their area, and they are supported by both coordinators and the local program area for primary care. This is just an overall schematic of the quite large amount of program areas within the knowledge management system. So at the individual level, this ALK assignment is mainly to establish routines within their area. This is done mostly as local agreements as to who does what between primary care and secondary care. And this process follows a structured mandatory foundation in primary care. All suggestions are sent out to all primary care physicians in Norrbotten, like a referral, you could say. Together with the responsibility and veto at publication of these agreements, this means that nothing is published without the explicit consent of primary care. And also within the assignment is to handle information to primary care, handle educational initiatives for primary care. Typically for the ALK organization as a whole, there are 2 days per semester and also 1 hour most Fridays during the semesters. As for financial compensation for this, the local clinic receives a compensation of between 2.5% and 10%. I'll stop there.
Yeah. Are there any questions? No. Thank you, Joachim. Joachim. Now next we have Pantea Hatefi, Jenny Kardell from the VIS editors, as well as Vibeke Gyberg from RPO. And I must say I've forgotten what that's called in English. Can you please?
Well, thank you, SVAM Stockholm, for the invitation to talk about our favorite topic. How do we make guidelines usable in primary care? And of course, an honor, we say Michael. We agreed about that, so it's not Professor Kid. It's an honor to discuss this with you, and of course, Joachim and Sarah. Sorry, I need to change slides. We have to change this. Okie dokie. My name is Jenny Kardell. I'm a GP and editor-in-chief of VIS, our digital guidelines in the Stockholm region. I'm also a member of RPO Primärvård with Viveka, as she will tell you about. And with me I have
Pantea Hatefi. I'm also editor at VIS. And I work at 2 RPUs also and at Läkemedelskommittén in the region. And at the Axelsbergs vårdcentral.
And I'm Viveka Giberg. I'm also a family doctor working at Söderbrunns vårdcentral, and I am the chairman of RPO, or the clinical program of primary care in Stockholm, Gotland.
And in contrast, Michael, as you know a lot about our midsummer feast, you probably know that in contrast to Norrbotten, Stockholm is the largest region in Sweden. We have a quarter of the population, 2.4 million inhabitants, and also the highest amount or share of the doctors in Sweden. Actually, so I think, Joachim, we share the same problems, but in a different kind of views due to our conditions, different conditions, I believe. Let me see if I can. Yes, VIS was founded in the middle of the 90s by a couple of family medicine doctors, together with doctors on South Hospital, Södersjukhuset in Stockholm. In the beginning, the guidelines was written by the secondary care for the primary care, but in recent years, we've changed that mandate to from family doctors for family doctors. We hope this supports evidence-based, as long as it's available, guidelines to provide high-quality primary care. And it's widespread use, as you probably all of you used this sometime, I guess. We have 230,000 visits or page views a month. We know our 1,100 family doctors in Stockholm use this every day, or at least several times a week. And it's used, like I said, all over the country, and also, Michael, in Sydney, Australia, and Hong Kong, and so on. Probably Swedes go abroad, but also some patients, maybe. We believe in clinicians-led leadership, so our editorial team consists of 7 family doctors, all clinical active, but we're understaffed. We have, all of us contains 1 full-time working employee. So that's one of our problems. We believe guidelines should be supportive, not prescriptive, rather provide guidance in our clinical work to enabling the clinical judgment and to retain a holistic approach. All our guidelines are developed in close partnership with our clinical program of primary care, RPO Primärvård, as Viveka will tell you more about later. And of course, other relevant clinical programs in other areas. We believe our most important success factor is our clear and strong mandate for primary care, from family doctors for family doctors. And we think to be used, it has to be useful. We need to center the clinician's view for the guidelines to be useful. Like I said, it's well integrated in the knowledge management, the kunskapsstyrning. And we believe this connect healthcare systems, our frameworks with the contractual agreements, avtal in the Stockholm. If you heard the recent program with our politicians and Åke, they talked about vårdval and all the different kinds of care systems that we have in Stockholm. So this connect that, we think it's important to show the responsibility in primary care and in secondary care for our patients' safety. And most important of all, our editorial team and our writers have no conflict of interest. Of course, there are a lot of challenges ahead, like Joachim told us about, as you all are painfully aware of, I'm sure, about all the multiple simultaneous changes in new guidelines, new evidence that's going on right now in Sweden and international. And also with the lack of horizontal prioritization that we're so dependent on. We see limited understanding in primary care perspective in other relevant clinical programs, though we've seen a quite positive change over the last year, and I think that's because of Vivica and RPO Primärvårdens work she will tell you about later. Development and the implementation of new guidelines, new treatments takes time. So that's our big challenge ahead. And when new guidelines are written, resources do not follow, so that's also something we need to work on. So, Panthea, how do we make guidelines usable in primary care?
Yes. Okay. So, how do we make the things we write usable? I'm going to talk about the different dimensions of clinical usability. The most important is the clinical judgment and our common sense. So we should always leave room for that. The other one is feasibility. Conditions and resources to implement, are they there? Are the resource consumption reasonable? And is it reasonable in a primary care content? And is it an efficient use of our resources based on our overall mission? Then we have the statutory ethical principles of resource prioritization. That says that those with the greatest needs should always be the priority. And we should strive for equal care. Vad ska vi se? Jag kommer inte ner där. Hur kommer jag ner där?
Nej, där.
Där, så. The healthcare system as well as guidelines are very immature when it comes to prioritization. It has difficulties in identifying those with the greatest needs for care and provide care accordingly. And then we have choosing wisely, or kloka kliniska val in Sweden. That says choosing care that is necessary, that provides evidence-based patient benefits and that are effective and that affects the health status and does not harm. And in the middle of all this, we have the individual doctor with a patient's list who has to think about horizontal priorities, about displacement effects, about resources at hand, and at the same time put everything in a primary care perspective. And above all of this is a natural system of knowledge management that lies like a dark cloud. So, what we need from our clinical guidelines is that, first of all, they have to enable best practice, make it easier not to do the right thing, simplify, very often guidelines make it more difficult and more complex. We get more to do. So we shouldn't assume that not following the guidelines is always wrong. Common sense says sometimes you shouldn't. Secondary, support, don't control. Provide guidance during patient encounters, not act as a regulatory tool. The decision lies always with a general specialist and who is responsible and who prioritizes. Respect clinical judgment, allow for the professional judgment and the holistic view of the patient. Reflect the real-world context, account for primary care realities, feasibility, displacements, effects, and practical implementations, for example, using time needed to treat. Prioritize by clinical importance, present interventions in order of clinical priority based on severity of the disease and degree of the patient benefit. Tailor to patient risk profiles. Avoid one-size-fits-all. Consider disease severity, symptom burden, risk of complication, frailty, polypharmacy, adherence, ability to self-care, and so on. And present evidence transparently. Include strength of evidence and clinically meaningful outcomes. For example, absolute risk reduction and numbers needed to treat. And last of all, flag low-value care. Clearly identify interventions with limited benefits or potential harm. What to de-implement or stop doing. Yes, Viveka.
Thank you. So great. So yesterday during the presentation, Michael, I realized we have a friend in common. Even though you're from Australia and I'm from Sweden, I have the great privilege of being clinically trained by Dr. Göran Schönell, and he was also my mentor as a PhD student. So we have one friend in common, even though we come from different parts of the world. I'm working 3 days a week as a family doctor, and 2 days a week I work with knowledge management as the chairman of the clinical program, regionalt programområde, primary care in Stockholm and Gotland. I will mostly focus on Stockholm today. So in similarities with what Joachim said in Norrbotten, we have a structure for our work. We have a working group constituted of 6 people that see each other at least 2 to 3 times a month, sometimes even more, because there's so many things that we have to deal with. We have a main group that is constituted of 20 people to represent the different professional categories, the different caregivers. As you heard, our care structure in Stockholm is very diversified. We have different caregivers. We want representation. We also have 26 primary care representatives and all the other clinical programs, de andra RPO:na. And that is to be able to represent the primary care perspective in all decision-making processes regarding healthcare in Stockholm. In addition to that, we have representatives in Läkemedelskommittén, the pharmaceutical committees, to also have the primary care perspective. So this is our organization. But what do we do? If you see these bubbles, if you think about them as an ID, there might be someone who's passionate about the disease, or there might be a new guideline that says we should treat harder, or there's a new process, we should do this. They come IDs from all sorts of initiatives. In Stockholm, we have gotten the mandate that these IDs has to pass through our RPO. And as you see, some go through. And that is because we are working, as many have said, with horizontal prioritization. This was something that people before my time in RPO realized that this is key for us to communicate. In order for people to understand us, we have to describe our reality. So what we've done is to map all planned and unplanned healthcare challenges. We have presented them in a list that we can send out to politicians, to the healthcare administrator, and to other caregivers to be able to show, look, this is what you're asking us to do. It's unrealistic. In addition to that, we have launched this year a list of questions that you have to ask yourself if you want primary care to do something. Is this necessary? Is primary care the right care level? What is the time needed to treat? What is the cost needed to treat? How many patients is it? Is it too few? Is it too many for primary care? These are questions that has not been asked in tradition. People have just pushed IDs into primary care. This we call real-world medicine. What is that? That is the best evidence available, But you have to put it into the context that you operate in and also connect it to resources. By doing something super well or excellent, we might make the care system worse as a whole. And we have also been given the mandate in Stockholm to say no. We can push back. And that is sometimes the best success of our work, that you as clinicians do not have to bother with some ideas and processes, that we have been able to stop them. But if something has been moved forward into the knowledge management system, what are we aiming to do? The first stop is the clinical guidelines, VIS, as you heard Pantea and Jenny talk about. And we want to adapt them to our regional context. But we also are working together with the healthcare administration, hälso- och sjukvårdsförvaltningen, to align it with the contractual agreements, to resources and who's doing what, that has to be aligned. And also we are discussing what level of care it should be given on. The next step is to educate. You cannot just publish a guideline and think that people will use that. You have to educate. And we are very fortunate in Stockholm to have a close collaboration with Academic Primary Care Center at KI. And that is not Kangaroo Island, that refers to the University of Karolinska Institute. And we have academic pharmacists and academic family doctors, informationsläkare, informationsapotekare, that through educational outreach strategy, they visit a certain amount of GP clinics. Every year, it's the same person going to the same clinic. It's continuity. It creates trust. They work with the actual data from that specific clinic and relate that to guideline outcomes. We also provide weekly updates for family doctors, for nurses, for rehab staff that also work in primary care. And we have every year 2 conferences that allow more elaborate discussions on complex topics. But you have to implement, you have to make it happen. And if you see these 2 boxes are green, we think we're doing this pretty well. We're not perfect and we can still be better, but it's okay. But here it's red or orange. And that is because we are not doing well on supporting the different clinics on how to implement or de-implement low-value care. But we started a project, but it has shown that there's not that much research on how to work with this in a complex organization as Stockholm. We're talking about 240 GP clinics, everything from big ones in the center of Stockholm to small ones that work in a context closer to Norrbotten. The final step is, of course, to evaluate, and that's also red-orange. We want to know, is the knowledge management structure, is it good? Are we useful? Is this process good? And we are following some data on trends. Are we improving management? Are we improving outcomes? Are people actually following the guidelines? This is a good trend that we're doing. But we want to be more specific. What part of this is good? And we also think that we can connect actual primary care research to this process. But of course, we shouldn't do that on our own, but we would like to enable for others to do that. And this should, of course, be a continuous process that helps to improve primary care. So what are the take-home messages for us? Most important thing that in Stockholm we have a clear mandate for primary care. And that's not only in the knowledge management structure, that is also in the health administration and also from politicians. They ask us for our input. There's a big challenge with uncoordinated care changes. They just pop up different projects without having analysis of, is this really a priority? There has to be an analysis before we do big changes. That has not been the tradition. We are pushing for that change. You cannot just say, we don't want to do this anymore, let primary care do that. No, we want more data. What should have priority? Maybe we are discussing now, maybe we should set the limit, just like the listenings talk. No, we're not doing more changes this year. The primary care physicians has already had 5 this year. Collaboration between key stakeholders, like other clinical care programs, others RPO, to also understand their reality. We have to listen. We have to understand that we have the same interest of giving the best care to the patient. But also the administration, the politicians. But for me, the most important thing has been dialogue with people who work in clinical care that email me, have you looked at this? Have you heard this? And then I can investigate that. Always keeping the clinical perspective at the forefront. It's when we enable the clinician to have a good working environment and make it easy to do the right thing where the magic happens for the patient. And to do this, we have to be in the real world. We actually have to be in where we are in Stockholm, with the resources at hand, with the context that we're operating in, not in often the utopic world of an RCT with unlimited resources in a study. That's what we want to say from Stockholm. Thank you.
Thank you.
Thank you. So, thank you very much, Vis, as well as RPO. There will be a talk about RPO tomorrow as well, when you can dive deeper into this. Now, Michael Kidd is going to tell us a little more about his experiences with guidelines.
Thanks, Sarah. And I'm not going to talk very long because I want to get to the questions and the issues, and you heard me talk yesterday. But I do want to tell you about why I'm passionate about guidelines and why I think they're so important in general practice. Yesterday I showed you a lot of the drawbacks and a lot of the cautions, but they're incredibly important. And my journey to guidelines started when I was a medical student, now nearly 50 years ago, in the late 1970s. And I was at my teaching hospital in Melbourne, in Australia. And in the teaching hospital, the clinicians were very worried that antibiotics were stopping being effective for some infections. Now, for those of you who are trainees, you may think that was happening 50 years ago. That's happening right now. It's been a problem over the last 50 years. So 50 years ago, we started getting resistant strains of Staphylococcus aureus, the methicillin-resistant strains, or MARS, and we were worried about superbugs developing. And one of the problems was that as new antibiotics became available, they were being used to treat everything. And then those of you who are old enough will remember this, and then we started getting resistance, patients who didn't benefit. So a group of clinicians at the hospital where I was based came together, GPs, clinical pharmacologists, infectious disease specialists, and pharmacists came together to start developing some guidelines. If someone had this condition, what was the first line treatment, second line treatment, third line treatment? If you're allergic to penicillin, what was the alternative treatment? And put them into a little book that as hospital residents we could put in our pocket and carry around. And being a member of the Medical Students Society, we were asked to promote the little book, and it was distributed and given to everybody, and we all got really used to carrying it around. And we'd see a patient, we'd see them with an infection, we'd look up the little book, look up the guideline, and we'd start to follow it. Over time, that initiative got turned into a company, a not-for-profit company, a bit like NU, or Vis NU, and started to develop guidelines for all other areas of clinical medicine as well. I eventually joined the board of that company. I became the chairman of that company. The company continues to work today. Of course, now we don't do books. Now everything is available electronically. It's integrated into electronic records. One of the secrets, though, of the success of the organisation is it's never taken funding from government. So it's never had government telling us what to do. It's been the clinicians who own it making the determinations about what are the guidelines based on the best available evidence. And conflict of interest, as you mentioned, has been incredibly important. The guidelines are put together by bringing together the experts in the field, and always including general practitioners, family doctors, looking at the best available evidence, developing the guidelines for our colleagues, and then promoting it to the medical students of today as well, so that we continue to have that culture over 50 years of developing the guidance and the rest of us using it. The company actually makes a profit through the sale of the guidelines, and it makes about $1 million US in profit every year, which is quite a lot of money. I don't know how much that is in Swedish krona, but it's quite a lot of money. And that gets turned into both continuing the development of the guidelines, but also it funds a foundation which allows us to promote the use of guidelines in low-income countries in our part of the world, in Southeast Asia and in the Pacific Islands. And it continues. So Hopefully, it will continue doing what it does. We haven't yet run out of antibiotics, but I think the concerns we have now about antimicrobial resistance remain just as important, and the importance of us using guidelines and adhering to guidelines together to ensure that we are able to continue to treat our patients with serious infections. I'm going to stop there. Thank you.
I'm hoping, yes, now I can be heard. So the reason why we have invited this wonderful group of people to come and speak with us is because as clinicians, we use guidelines daily, or I do anyway. And so then it's important to know, how have they been compiled? Who does this? And what do they consider when they do it? And that is one reason why we wanted you to explain how do you do your work. And we've talked about many problems with these guidelines. Yesterday, actually, Michael had a wonderful talk about the different problems that can arise with guidelines. For example, the too much information. How are we supposed to deal with all of this information? Also, that sometimes it can feel like an external demand if there's a guideline. No, that's not how it's supposed to be. And I hear that this is how you're all working, to have it grassroots, from up, from the floor, and also using evidence. And it's also important to know this evidence. Do we know if it's even, how strong is the evidence? Is this something that I can trust? Another is, of course, prioritization. We have many patients who might have many illnesses or who have a socioeconomic situation that doesn't really apply. How do we deal with this? And also, this is something we'll discuss further. Also, the single diagnosis guidelines. How does that apply to our patients? Should we maybe look at symptoms instead? How can we work with this? And that's something I would very much like to discuss with all of you. So if you can come up. And of course, with all of you. So if you have questions, we're going to have 10 minutes at the end for you to raise questions. So please save those questions, don't forget. So one thing I was actually very curious about, Joachim, you mentioned in your talk that you had made some kind of a prioritization guideline, or can you describe that a little bit more? What kind of work you've done with that?
Well, Norrbotten is a small region also when it comes to resources, so we don't realistically have the ability to develop our own guidelines. That's quite an obvious difference for Stockholm and your organization that is much larger, much more capable. But we can make prioritization within what we know something about, which is primary care, our expertise. And we saw a need as probably, unfortunately, I didn't have the opportunity to listen to you yesterday, but you surely mentioned that all of these guidelines with all of their enormous amount of knowledge are useless if we don't say, okay, but what's at place number one? It can't be everything, but in the guidelines you get the impression that it is like that. So we have developed a structured way to do this. I would say that it's highly influenced by time needed to treat and time needed to implement, although maybe not using those quite words, but inspired by choosing wisely and Mina Johansson's work. So we use that on everything that someone tells us to do, mainly the specialist clinics, I would say. That's our main issue in Norrbotten. The specialized care wants primary care to do this because it's simple. And we don't have the resources to do it, so primary care can do it. Mm-hmm. And we don't accept that anymore without doing this analysis and see what are the consequences. Very similar to what you described, Viveka.
Mm-hmm. And is there a way of, say, for example, if a patient comes in with, COPD and they have heart failure and maybe they're depressed as well, is there any kind of horizontal prioritization?
I wouldn't say that we're quite there yet, but we are getting a fair amount of understanding from other parts of the healthcare system, and also it's beginning to rise on the political side also. So slowly but steadily we're gaining influence for the primary care perspective of multi-dimensional disease.
And how do you in Stockholm work with the horizontal prioritization, or how do you think about this?
I think that when it comes to politics and resource allocation, you have to have a horizontal prioritization. But it's unavoidable that it has to be done by the physician with the patient at hand. You can't expect someone else to do it, because you have to know the patient data, and you have to know the patient's conditions. You have to know the patient's will. So the prioritization is just not only done by me, but also the patient. So maybe I want something, but the patient wants something else. So you have to take in the patient aspect, and for that you have to do it in the room. So you have to be a physician, and that's why we say that these are just guidelines. It's just supportive. Pick what you want. Pick what's best for your patients. Pick what's best for you. And just make it well for your patient. And I can present what is good care for my patient, but patient says, no, other quality is more important. And I say, okay, fine. Then, but we skip it. So what's important for you? So we go. So guidelines are just a small part of our work. They shouldn't take as much place as they do. I think sometimes they get too much attention, but they're just a way of transporting information. Because we physicians can sit and read every single article and RCT and so on. So we need to have it compromised. But that is not the most important thing we do. We take care of the patient. We have relationships. We have talk. We have continuation and so on. So the most important for us in primary care is other aspects. The guidelines is just a small part. I think guidelines are more important in the hospitals than for us.
Thank you, Pantea. Viveka, you had something to say.
No, I think that we have to realize the limitations of what a guideline can do for us. And also what we're all trying to say, I think, is to emphasize the complexity that we work in, both on the individual patient level, but also as a healthcare system. But that's what we're trying to do with our educational system, to allow for discussion. When someone comes out and visits the patient or the clinics and discuss guidelines, there's a discussion, there's a conversation. It's not to do this. No, okay, but in this context, you have to. There's different levels of understanding and teaching, and the guidelines are only the surface. We have to give time for this more thorough clinical discussion that we share between each other. That's when it becomes real and interesting.
Just to one, I think we have a semantic difficulty when it comes to the term knowledge management system. It implies that the knowledge is managing what we do. And of course, that's true, but the guidelines are not the knowledge that manages us, it's our judgment. And all of these aspects that you have just mentioned. The guidelines are just guidelines. And I have a feeling that especially the standardized care process and well-founded suspicion of cancer for different things, they are not seen as guidelines. They are seen by many as, you should do this, otherwise you're wrong. And that, I think we have a challenge, because we have to whether we like it or not, we have to somehow handle it.
Thank you.
And also, you shouldn't see the guidelines as cookbooks. Very often, when I speak, why does it say that? I'm like, okay, skip it. If you don't like it, use your common sense, use your judgment. If you think if it's not good for you, if it's not good for your context, if it's not good for your patient, skip it. You don't have to follow it. But I think many young physicians that come, they want it, they need it, they ask for it. And that for me is a problem, because what we do is a handicraft that you can't read in a book. You have to learn it. You have to learn to practice it. And the guidelines are just a help for the information, for the knowledge. But that's a very small part of it. You shouldn't give it too much attention, according to me.
I think that can be a risk sometimes with these guidelines, that especially, I mean, if you're a younger doctor or if you're reading a guideline and you're not so sure about that particular illness, you see it as, oh, I need to take this test and that test and that test and that test, otherwise I'm missing something. Is there any way that you can help create the guidelines so that the person reading the guideline can understand that, okay, this is a suggestion, but it does not mean that I have to always look at all of these blood tests? How do you work with that?
First of all, we try to minimize the amount of things you do. So everything, they say, take HB, and I ask, why? Why do you want me to take HB? Oh, because of this. Okay, then I write it. So if this reason is good for you and for your patients, then you know that this is a good measure. But also you can choose not to do it, but you have to know why you're doing things. And that is one of the problems. We never explain why you're going to do things. We just say, do this, but we don't explain why. So if you explain why you're doing it, then you can choose to either do it and also not to do it.
But there's also the responsibility from the the management in the kunskapsstyrning. We have to help our clinicians to do the prioritization horizontally, like you did. You start with 5 vårdförlopp or something this year. We cannot do more than it. If we start doing this, we stop doing this. We need to help our clinicians with the prioritization. They cannot do everything by themselves. So we have a responsibility with our guidelines. We need to show, okay, if you need to do this, you must stop this, or you need less time on this.
When you mean vårdförlopp, can you explain what you mean by that?
Sorry. What I talked about, the national guidelines, we have this kind in the national knowledge management. We have different kinds of new guidelines for the whole care system, not for the primary care, but also for the secondary care. So that's like hypertension is on topic right now. We have a lot of ambitious level
goals, or
sorry,
ambitious goals in terms of what we need to do.
Goals and treatments and different kinds of how to take care of the patients. So we need to take those one at a time, like you do. To see, okay, what's in it for primary care? What can we do this year? What do we have? What kind of education do we need? What can we take? What do we take away?
You have somebody from above, but another organization saying these are the things that need to be focused on, and then you're given many at the same time. And in that, you need to somehow choose what will be focused on this year. I think that's something that a lot of us don't know.
No. Perhaps.
One good example of this, I think, is one that is on referral right now is the care process for prostate cancer. It's more than 300 pages long. I mean, it's not reasonable for a single primary care physician to know all of that. And, they need help to see what parts of this enormous book should I read and what parts should I not read. So, and that's just for one disease.
It's very hard to keep up to date in general practice. Let's face it. You know, I think where the guidelines can sometimes be helpful is when you're at the early part of your career and you see a patient for the first time with a condition, and there's the guideline. You can work through the guideline with your patient, work out what's going to work for that person, what's not going to work for that person. With experience, you now know that. You don't need to keep referring to it. But what you don't know is when things have changed. And that's why our continuing education programs are so important, to try and keep us up to date. I hope you don't do in Sweden like what happens in some other countries where GPs get their continuing education from pharmaceutical representatives trying to push the next drug along. Fortunately, that doesn't happen in Australia anymore, but it does happen in other parts of the world. But now, as we mentioned yesterday, we've got our computers to help us, and I am interested in knowing, how many of you have computers which will give you advice while you're seeing your patient? So you get alerts, and how many of you have that turned on? And how many of you have turned it off? Yeah? And why have you turned it off?
In my case, it was constantly talking to me all the time. So I thought it interrupted my work.
Yeah.
And it disrupted my process of thinking. And also, sometimes I think the interaction, pop, I want to focus on the patient. I don't want to have
yes.
pushed into my dialogue and my presence with my patients. And I didn't find it helpful compared. There are some tools that are more silent in our computer systems, but then I make the choice to use it. It's not constantly giving me feedback. So at my clinic, we are 8 family doctors, and 7 of us chose to turn it off when we got the choice. So I think it's not really ready yet.
What I think I'd find useful is if the artificial intelligence in the system actually, at the end of the week, said to me, would you like a report on where you haven't adhered to the guidelines, and have a look at why that is. And maybe then I'd be learning a little bit if I was out of date, or I could say, yep, but it was totally justified with the patients that I was seeing as to why I wasn't doing that.
And to some extent, we can do that. But it's hard to, it cannot adjust for if you made the conscious choice of not adhering. But we can, through some computer programs, ask, what are the patients that have a really, really high HbA1c, and you can distract them and look, why is that? Have we missed them? Or you can also look at how many patients who had a heart attack has not been here in 2 years, or something like that. But that might be a choice that we made. But we have also that you have to do these projects in Stockholm every year. That's actually in the avtal, in the contractual agreements, that you have to do a improvement project that is run by the clinic, where you can look at these things. But I think it's really interesting, because what you realize is that it's usually not what you think at first glance.
I'm also wondering about these guidelines. Should we also have what not to do in the guideline?
Yes, we are actively working on it.
Yes. Like I said, if we start doing this, we have to stop doing this. And when Pantea told us about the low-value care, and we need sometimes to show ourselves, we need to stop doing this, or we need to put the responsibility on the patients, like you told us yesterday. The self-care is most important. So sometimes, yes, we need guidelines.
Or in which cases this might not be applicable. Say for frail patients, for example, or is that something that you do?
I would like to say yes. But there are very few things that we do that are right off the table unnecessary. Because it would be easy to stop doing this, as the woman who spoke, I don't remember her name, this morning just before lunch, said. All of these things that are in the guidelines, they are to some degree useful, but to who and to what group? That would be very much appreciated in the guidelines, I would say. Among elderly people in nursing homes, don't think the same way about blood pressure as you do about a 40-year-old otherwise healthy, or 65-year-old with cardiovascular disease. Those are vastly different cases and groups of patients. And that kind of support would be what would you call it? Practical epidemiology, clinical epidemiology support. When to use guidelines and when to abstain from doing things.
I think that most of the low-value care that we do is that we do things without thinking about it. I have a system that always, when I'm going to, for a lab result, if I'm going to click on it, I always ask myself, why am I taking this? What is the question? Is it going to answer my question? Do I know what I'm going to do with the result? And if I can't answer those questions, I don't take that test. And I think it's very good to think about it, because very often you just click without thinking about it. And also, if you want to just continue, you have a patient that has low kidney function and you're going to follow it, and you say, oh, since I'm taking that test, I might take this at the same time. But why? That's not your question. But so I think very often we do things without thinking about it, and we have to question ourselves. Why am I doing things? So I think, yes, it should be above, but also we have to be more critical on ourselves and what we do.
And also responsibility, once more, in the guidelines to tell you, consider these tests, not just take them.
We often write, consider, take this, maybe you should do that. What I want us more to learn is to pick up the patients that have the severe diseases, because that is, for me, the most important. Very often the guidelines are written just one-dimensional. That's the same. So we have to make place and make the user aware that how sick is your patient, how is the symptoms. And if you have a very sick patient, focus on that patient. And if you feel, if it's a 40-year-old diabetic with only metformin and HbA1c is perfect, skip it. I see you in 3 years. And focus on the sickest patient. And that's what we are very bad at, because we meet all the diabetic patients every year. It doesn't matter how sick or how healthy they are. So we have to learn to prioritize the patients who need us the most, and we don't do that. So at all levels, but also at our level, we need to think about that.
I think besides that, it's also that we have an unselected population. And these guidelines are written for specific illnesses and people who are really sick. And in that sense, this person might not have, whatever illness it is. They probably don't, but they have a few symptoms that correlate. And so, then maybe I will take all of these tests. And I think that's exactly the one of the take-homes of today, that we need to individualize our care and use the guidelines as a guideline and not a law book.
And of course, one of the challenges with that is the patients with comorbidity, and especially those with multiple complex comorbid conditions, and the fact that there are no guidelines for many of the patients who come in our door and who we're providing care for. It is an area that primary care researchers have been looking at, and it started about 20 years ago, trying to see, could we develop guidelines for someone with diabetes and depression, for example. That was one of the first comorbid guidelines that was developed by primary care, but it's been very slow, and part of the reason is that the research isn't carried out. The people who have comorbidities are excluded from the research trials for so many treatments, which makes it really challenging. However, we have the knowledge about this because we are experts as family doctors in managing people with complex comorbidity. So we have experience, and we need to share that. And again, it may be that artificial intelligence makes this a solution, being able to bring together the experience from our records about what we did with other patients that we've seen who may have been similar to the patient who's in front of us now, or it may be full of hallucinations and nonsense which we can't rely on. Comes back to, you have to make a decision based on the patient in front of you and the best that you can do.
Going back to evidence then that would be one field within primary care that we might be able to research more, just in terms of patients with comorbidities. What happens with these medications they use? What kind of treatment do we notice is the best? And that would be really interesting, because then you would have evidence that you can use as a base for a guideline. So if anyone is interested in research, that's one way to go.
I think it's also the balance, because so many of the guidelines are based around pharmaceutical interventions, so using a drug. And as we know, as family doctors, often there are non-pharmaceutical interventions that are going to be more effective in helping our patients. But again, the research has often not been carried out there. But we are seeing more and more research, especially through primary care, on other ways of managing conditions than just relying on a pill or an injection. Having said that, watching what's happening with the management of obesity worries me, and the guidelines are coming behind the rollout of different treatments and the way different treatments are being pushed at us by the pharmaceutical companies and by expectations from our patients, which of course are probably being driven through social media by the pharmaceutical companies as well.
So, we have been speaking for a while now, and I feel it could be good to include our audience. Mark, you have a question. Is there a microphone?
So, thank you. Very, very good talk. Janet noticed that our Swedish colleagues, when they talked, this was a lot about we and them, especially compared to secondary specialists in the hospitals. I don't know why. There may be a lot of reasons, maybe because our guidelines, especially before, was based on secondary care data or written by secondary care specialists. But Michael, have you noticed the same perspective in other countries that you have experience in, like between the perspective from primary care GPs, or is it more trust?
I think that, and we saw it with one of Janet's guidelines she showed us this morning, had the endorsement from the College of Family Physicians of Canada sitting on the front page. So, maybe the guideline had been developed by a multidisciplinary panel of consultant specialists and GPs and pharmacists and nurses and others, but then it was endorsed by the college for use in primary care. What I also noticed was that two of the other guidelines didn't have the endorsement sitting on there, and whether that is still waiting to happen or whether the college has said maybe this is not for general practice, I'm not sure. But we need to be actively involved in determining what information we're going to use in general practice, rather than just accepting what's dumped on top of us by colleagues or governments or industry or by others. And that's why I think the most effective guideline groups that we see around the world now are those which very actively involve general practitioners or are led by general practitioners on behalf of the patients. And I want to do a shout out for our colleagues who actually devote some of their rare spare time to developing the guidelines for the rest of us, because it's an incredibly important and valuable professional contribution to the health and well-being of the people we look after. So thank you to those of you who are doing it.
Do we have any more questions or comments?
Thank you for a very interesting discussion. And I started studying medicine in the beginning of the 1970s, so I've been around for a longer time. And I've also been working in hospitals and as a general practitioner, but mainly as a regulator within the government. And as you said, the guidelines are mainly made for getting new drugs on the market. And I've been involved in these guidelines, both in Socialstyrelsen and Läkemedelsverket. And the ones that are selected, when we were two pulmonary physicians at Läkemedelsverket, only one was allowed to participate. And we were the only ones that didn't have any connection to the pharmaceutical industry. All the other ones were involved, of course. And they were fighting to get the drug that was going to be introduced in a certain level, where they could easily get it out then. And you mentioned the hypertension guidelines. I am a cardiologist as well, and I've been involved and participated in some of these meetings the latest year. And I was shocked when 2 years ago at the meeting, when without any discussion, they reduced the level for LDL to be below 1.3. And I said, this is incredible, you know, because cholesterol is a life-important substance, you know. And the statins not only inhibits the production of cholesterol, but also 2 other very important lipids for life survival. Ubiquinone and another one, you know, that's, if it's not produced in the body, there is a genetic deficiency, the child will die within 3 years. And I've been working 6 months as a general practitioner on Gotland, in Örebro, and in Värmland, and I see these adverse reactions. You wouldn't believe it, you know. And what I do, I check up the total cholesterol. Nowadays, the doctors don't look at the LDL. So when I have a patient coming in, you know, walking, stumbling in there, you know, I check up the LDL cholesterol is 1.4, but then the total cholesterol is 2.6. You can't reduce LDL with statins without reducing all cholesterol. So everyone that has cholesterol values below the reference value should be 3.9 to 7.8, you know, and if you have 2.6, you know, you will have, cholesterol is important for all the cells in the body, you know. So what I did, I checked up, as you did ChatGPT, that they was kind of complaining about. So I asked ChatGPT, you know, what happens in the body if you reduce cholesterol, you know, below 0? And I want you all to do that.
Thank you. Does anybody else have a comment or a question?
I can comment on the us and them concept there, because I think it's a good observation, and I think there's something to that. And I think that through this knowledge management structure, we finally have a meeting point. But traditionally, I would say that secondary care has been given the right to tell primary care what to do. And I think there is a historic conflict in that. Now we have changed that, and that in place creates some friction, because some get upset when they say you should do this, but we say no, we don't, you should do it yourself, or that we also have a place to have a voice, that we've given this mandate, that we are now able to push our ideas and our views on how care, primary care, but also secondary care. As an example, we have several times now told other areas that you have to take care of side effects of medications you give to your patient yourself. You're the responsible doctor. But in several situations, I can mention one example, as you all know, ADHD is becoming a big disease, and they're getting their medicines. A very common complication is that you get a higher pulse and a higher blood pressure. In Stockholm, they just referred to us and said, the patient have higher pulse, higher blood pressure. Now they cannot do that. The psychiatrist has to take responsibility for the side effects themselves. They have to assess the patient before they put them on a drug and take care of the side effects. We have pushed for them to be the first line somatic care for their patients. Those of you who work in Stockholm know that the concept of first line psychiatric care is what we do in primary care. So we're trying to make sure that we contribute to patient safety and the care systems at the right level take care of the patient. And I think what you're aiming at, that we can only together do this. Like, it's also for us to understand their perspective, and we have to listen to them as well. And I think that that's one of the best things. There's a lot of things that are hard to understand and not perfect with the knowledge management system, but there is a place where we're equal and we get to talk about how to do the best thing for our patients, because that's, we always have to keep in mind that that is the goal.
Thank you. That's wonderful that you're working with. But I'm thinking, is there a document or a website where we can access the information as to what it is we don't need to do that we are told to do by secondary care? Because I should know this.
You know, that is
but
a
I
great
don't.
question that we are working right now, because we have noticed that even though we have these big collaborations and sometimes we spend hours and several meetings on negotiating, and then we formulate, we get it into the avtal, into contractual agreements, and it's stipulated on the official websites, we continuously get questions on it. Do we have to do this? Do we have to do this? So I don't know how to do it in the best way, but every year we are releasing a report that you can find from the RPO Primärvård. But this is something we have to figure out, that when we've made decisions, how do we actually implement them? That's what I had on the slide there, that it's very complex to implement it in so many units, and then you also have to get the secondary care to change their behavior, because there might be something that they've done, that this is their process, this is their routine. How do we de-implement this behavior in whatever relevant structure of the system?
We have a newsletter, and we try to write in the newsletter those things that are new. It's every quarter we give it away, so sometimes. And we also have tips, like other things that has not to do with this, like referral regulations and other things to help our colleagues with that. So.
I'll get you soon, Camilla, but just one more. Is it possible to have it then in VIS, for example, that you have another besides the illnesses? News as to what is part of primary care and what is no longer, or something, so that you can easily click onto that, because newsletters have a way of disappearing. That's just a suggestion. Yes, Camilla.
Yeah, I was just thinking, I'm working in Gotland also and in Stockholm, but there we have this, we have these letters actually in a, what is it called, on the regional website, where you can see, this is actually the new guidelines, like this is the belongs to the orthopedics table, if you say so, and this is what we should do. So they kind of try to, well, you can look there if you're unsure, should I do this, or is it the orthopedics that do that, for instance, or so they try to work on it like that, and you can always look up these documents. So
I think on all guidelines at VIS there is specified like who should do what, but it's not sufficient in all contexts. Like for instance, zoledronic acid, we give it for osteoporosis in primary care, and we should do that. But now, since several years back, it's said in Stockholm we should not give zoledronic acid, for instance, for a cancer patient with closer intervals than the regular ones. But even though that is documented, communicated 2 years ago, it's still going on, and I still get questions about that very often. So that is a question we have, that thinks that this is not something we should do. Maybe we should put it in the guidelines, maybe we should do that.
One perspective on that, being in a region that's 1/10 of Stockholm, we have the same structure, that primary care does this, secondary care does this, but it's quite general, it's not suitable for details. So the details come down to the ALK representative within the local program area. There is one person, one individual that gets these questions and discusses them with the specialist clinic and comes back with an answer. So within a smaller region, a smaller context, that's possible. In Stockholm, probably not. You need something bigger.
Yeah, but I think that is why it's good too that Gotland is together with Stockholm, because I've learned so much about how you can solve problems. If you're like a closer group, there are many problems we have in Stockholm that are sorted out a long time ago at Gotland. So it's inspiration too.
Thank you. Our time is coming to a close. Thank you for coming here. Just one short take home from each of you. Do you think you could tell me something that you bring from our discussion? Viveka.
Ever since I started working with this, I feel like inspired about like what family doctors can do and how important we are to ensure the best care for the patient and the system. That our perspective in a lot of meetings and committees that we're present in can really contribute. So I would like to encourage you to, as Michael said, to participate, be a voice, because it's important.
Thank you.
Yes, I agree, and I would say I come back to our dogma that primary care and no one else should define our area of competence. We are also specialized care, but on primary care. And if no one else does it, then it's not going to be done. No one else is going to do it for us. So it's good that we're quite good as physicians as identifying problems, but we also have to take the next step to engage in solving the problems. Yeah.
Thank you.
Well, as a part of the editorial team of this, I have to say, use your clinical judgment. This is not a cookbook. And until we've solved the prioritization problems and all so use your clinical decision, I think.
Thank you. Mine is know your worth. We are specialized and guidelines are there to help us, but you have to be able to say no, put boundaries, and our primary care is the patient and not the guidelines.
I love that. You've taken my taken my messages. I was going to say, use your common sense. We have our common sense, and one of the things I love about family medicine in Australia, our college has as its logo cum scientia caritas, which means with scientific knowledge and tender loving care, and that's the work that we do in family medicine. So use your scientific knowledge, use your tender loving care, and if that fails, use your gut instinct as well. Thank you.
Thank you very much.
Thank you.
We have a few gifts here for those.